And this specific tube, it is a plastic tubing which is radiolucent. You guys remember that term, radiolucent? Which means it can be seen under a radiograph. So you can see the stent here, it's radiolucent. It's a long plastic tubing with two pigtail ends. One end will sit in the kidney and the other end will sit in the bladder. How is this inserted? Well, it's inserted through your back. Why your back? Okay, where are your kidneys located?
In the back.
In the back. This is done in either the operating room, but we do it mostly in radiology. So we'll place our patient prone, face down. We will prep the side, the surgical side, and do an incision from the back and into the kidney. And then we start putting wires and different gadgets in there to lace the catheter at one end of the kidney and the other one down to the bladder. This procedure takes about maybe 15 to 20 minutes. The whole purpose of this stent is if you have a blockage in your ureter, this plastic tubing will help empty the kidney of urine and into the bladder without any type of obstruction or blockage. It acts as a bypass. Okay? It may be permanent, it may be temporary, depending on the pathology or condition of the patient. So yes, we do this in the OR, and we also do it in IR, which stands for interventional radiology. Okay? Any questions here?
So it's almost the same thing you do for an artery in the heart, right? Just
Same thing we do, yeah. It's just a different tubing, a different vessel. All right, the other one here is the retrograde, which means going the opposite direction, right? Retrograde. This is a retrograde pyelography or pyelogram. The patient will be placed, this is done in OR. Why in OR? The patient needs to be heavily sedated. This is a painful procedure, so they have to be heavily sedated. They'll put them on a cysto table, like so. Patient is put in a modified lithotomy position, okay, with the leg stirrups. And then the doctor will put this thick pipe, I call it a pipe because it's so thick. It's not like a regular tubing. This is a very thick tubing that goes up the urethra, into the bladder, into the urethra, and then into the kidneys. There is a scope here so the doctor can visualize through a viewing scope the lining, okay, the different structures through the scope, but it also allows them to hook up a syringe here at the other end and inject contrast into the urethra and kidney so we can do a radiographic study of that as well. Okay? But this is only done in the OR. Okay?
Or removing any blockage over there, right?
Or yeah, so yeah, also this is done to look at the ureter to see if there's any stones in there, and they can pick it out. Yeah. Okay, any questions? All right. Let's talk about the different types of urinary catheters. We're going to go from the basic to the more complex. The very basic here is a straight catheter. Nothing too fancy about it. It's a straight catheter. It comes in different lengths because it is gender specific. Longer for males, shorter for females. It's a single lumen, which means it only has one opening. Single lumen, one opening. And this is used to obtain a specimen or to empty the bladder. Obtain a specimen or empty the bladder. Next one here are indwelling catheters. Indwelling catheters. So indwelling catheters means they're going to be staying in there for a period of time, right? It isn't just put in there and remove. It's going to stay in there for a longer period of time. The first one here is what's known as a Foley catheter. Have you guys heard of Foley catheters? Okay. A Foley catheter is inserted and left in place to allow continuous drainage of urine. So the catheter is left in there. Okay. The catheter is then hooked up to a drainage bag or drainage receptacle, so there is continuous emptying of the bladder. Okay. So the Foley catheter has two tubings. One to drain the bladder, and the other tube has an inflatable balloon. So when the catheter is placed into the bladder, we will inflate the balloon so it doesn't get dislodged. So the balloon is inflated within the bladder. Can it still get dislodged? Do you know who was famous for pulling them out? Me. Okay? Yeah, I was famous for pulling them out. Okay? There was a period of time where I worked in the CT department. So my transporters or orderlies, whatever you want to call them, brought my patients down from the floor. They got in a habit of tucking in the receptacle underneath the mattress. Okay, so they wouldn't be hanging off to the side like that. So when they came into our department, when they're coming down in the bed and we're getting ready to slide them over onto my CT table, now when we slide them, we are jerking them off the bed into the table. Okay? Well, imagine me pulling them over and all of a sudden you hear, it's like that, it's real sound, it's like, and I went, damn it, I pulled another one out. Okay? So we had to change the protocol. It wasn't just me, there was a lot of people who were doing that. So we had to retrain our transporters that when they come down with a urinary catheter like this, we have to be able to see it on the side of the bed, on the side of the wheelchair, but somewhere where we can visually see it and not hiding or tucked away underneath the sheets or underneath the mattress. Okay? We also had to retrain the technologists to lift up the sheet or blanket and see if they're attached to anything before you move them. All right? So they changed the protocol after that. It hurts. You hear, oh! Oh, crap. Okay. Remember, it's a rubber balloon, so it's very pliable. Okay? So even after it gets pulled out of the bladder into the urethra, it's still pliable. So it hurts a little bit. I should say, I don't know, it never happened to me, so probably hurts a lot, I don't know. Okay. All right, so the next one here is the Alcock catheter. Now we have another lumen. You have you have a balloon, one to instill or insert, and the other one is to drain. Okay? So here's your Foley. You got two lumens, one for draining and one with a balloon. Okay? So when you inflate the balloon, it remains inside the bladder. All right? Then you have three, one for drainage, one for administering or instilling, let's say, you're doing a lavage, okay? An irrigation, you're cleaning it out. So you're flushing the bladder out with some kind of lavage or medication going in. And then you have the other two for drainage of urine and other things. And the third one is for the balloon. Okay? Any questions?
Do they use any lubrication for it, or?
Oh yeah, you have to. Yeah, there's lubrication. For the male, it's a lot easier to do it, okay, because you know exactly where the urethra is. Now for females, it's a little bit more complicated because the urethra is very short. You have to have the women actually spread their legs, and sometimes you need a flashlight to see exactly where you're putting in that tube. Okay, but it has to be lubricated for easy insertion. Okay, any questions? All right, unlike the gauge, I should look it up. You remember how you asked me, why if the gauge number goes up, does the diameter get smaller? Okay, so a couple of my students stayed after class last week and asked me, you guys remember in needle gauges, as the number of the gauge went up, the diameter of the needle went down, which didn't make any sense? Well, I looked it up, and what happened was when they made needles, they adapted the wire industry practice. Because when you talk about wires, the diameter of wires are measured in gauges. So the number then was associated with how many times did they need to scrape that wire to get it to the smallest diameter. So let's say if it was a 20 gauge, the thick wire had to be scraped 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, all the way up to 20 until they got a 20 gauge, a very thin wire.
Makes sense.
Does it make sense?
Now it does.
Yeah, now it does. I was like, dang it, I need to look that up. I love Google. Okay, so that's the reason for gauges. With urinary catheters, it's the opposite. Okay, so it is directly proportional. The unit that they use here for catheters is French sizes, French. So one French is equal to 0.33 millimeters in diameter, or 13/100th of an inch, or 1/77th of an inch. Do you need to know that? No, what I need you guys to know is that the diameter of urinary catheters are measured in Frenches.
And it's proportional.
Yeah, and they're proportional. And they go from 10 to, about 10 to 28 is average. They got smaller ones, they got bigger ones. It depends on what they're used for. Okay. Any other questions? So although these are called urinary catheters, they can be also used for other things. Like they can be inserted inside a wound opening, yeah, to drain any type of wound. Okay, so they can be inserted in other things. Okay. Sometimes in pediatrics, instead of a feeding tube, they'll put one of these down as well, down the nose into the throat for pediatrics and babies to feed them. Okay. So they're urinary catheters, but they are multifunctional. All right. Suprapubic catheter. Suprapubic catheter. So a suprapubic catheter, you're creating a surgical opening, an incision from the abdominal wall and into the bladder. The purpose of this is if there, for some reason or another, we're trying to avoid the normal urethral route. Okay? This is also known as a cystocatheter. Again, placed directly into the bladder from the abdominal wall. This is done to divert the normal flow of urine from the normal route, okay, out the urethra. Probably because of gynecological surgery, probably because of urethral injuries, maybe because of prostatic, as in prostate, prostatic obstruction, chronic incontinence or loss of bladder control. Okay, so again, an incision is made from the abdominal wall into the urinary bladder. We do this commonly in radiology, so we do this too. Okay, so tube gets placed in. You'll notice that there is a plastic plate right here going across that sits on top of the abdomen. So we can either tape it down or we suture it on into the skin. Okay, the doctors usually just like to tape it down, because once you're making incisions into the skin, you're also increasing the chances of causing an infection, okay, because you're breaking the skin. All right. Now, because it is considered an indwelling catheter, just like the previous pages we were talking about, are there good chances of infection? Okay. We talked about this in the first and second week. Indwelling catheters. The longer that a catheter dwells inside the patient's body and communicates with the outside in your inside world, the greater chances of those creepy crawlies crawling up that catheter and into your body, causing an infection. Same thing here. So here we have to constantly monitor the site, making sure that it is clean routinely and also dry. What do we know about microorganisms? They like to harbor where? In
Moist areas.
moist, warm, dark, yeah, those type of places. So we want to keep it dry and clean. Okay? Now, I have footnotes down here. Any of these catheters that we're talking about, if they are connected to a drainage bag or receptacle, that drainage bag or receptacle must be below the site of the tip of the catheter. In this case, the drainage bag must be below the bladder for it to drain. If you hold that receptacle bag above the bladder, if this bag is higher than the bladder, where's the urine going to go? It's going to go back into the bladder. Okay? Now you're going to cause unwanted pressure from overfilling the bladder again. Okay? So you can cause the bladder to rip and tear, and you can also cause an infection. Those two things. Okay? So the receptacle or collection bag must be lower than the bladder. Any questions? Okay. Okay, then we have the condom catheter. It's just that, it's a condom. For males, of course, right? Soft rubber sheath placed over the penis and secured with a special adhesive material. This is externally applied to male patients. The problem with this is, so they're put on for those who are incontinent or comatose. Okay? They may be susceptible to urinary tract infection because look at it. All it is just a rubber sheath, and you've got the tip of the penis maybe swimming around any residual urine at the tip, right? So it can increase the chance of infection. It's not clean. All right? So this is for short term, very short term, because it has to be constantly changed every 1 or 2 days. Okay? It's not meant to be there longer than that. All right? And just like anything else, avoid pulling or twisting of the catheter, especially with males. Be nice to us.
This one comes out very easily, isn't it?
It just rolls right out.
I never heard of these.
Yeah. We do this a lot in the cardiac cath lab. Yeah, so we place this in the cardiac cath lab. Only because we medicate our patient and sometimes they become incontinent and they just kind of pee spontaneously.
Just pee or both ways?
Huh?
Does it go both ways or just pee?
Pee.
Oh, okay.
Yeah. So we put those on. And then for females, we put in we're mean to the female patients, so we get a urinary catheter. All right. Any questions? All right. Let's talk about feeding tubes. Nasogastric or nasoenteric. Okay. Nasogastric, the tip of the catheter goes into where? To the stomach, right? Gastric. And then for nasoenteric, the tip of the catheter goes where? In the small intestines, usually in the duodenum or the jejunum of the small bowel. So it goes past the stomach into the first portion of the small bowel, which is the duodenum, or the second portion of the small bowel, which is the jejunum. Okay? Are you guys familiar with NG tubes? Have you ever heard of NG tube? NG tube, nasogastric. NE tubes, nasoenteric. NE tubes. These tubes are also made out of plastic, rubber, or silicone. They're inserted through the nose into the nasopharynx, the back of your throat, down your throat, into the esophagus, and into the stomach or the small bowel. So it is inserted mechanically, but we also enlist the assistant of the patient. They're awake when they're doing this, okay? So they're swallowing for us. So they're awake, we're putting the tube down, they're swallowing, they're gagging, and they're trying to swallow and they're gagging. You keep trying to push that thing down their throat. Okay, should it be lubricated?
Yeah.
Yeah, it should be lubricated, be nice. Okay. It's done usually in their rooms but we can also do this in radiology with the assistance of using fluoroscopy to see it and guide the catheter down. Okay. The whole purpose of this tube is both for diagnostic and therapeutic means. Okay. When this tube is inserted, if they have an obstruction, if they've had surgery in their stomach or GI system, naturally what happens is in the healing process, your body becomes bloated. So you have this gas buildup. And you also have your body producing all these secretions, causing again your stomach to bloat. So we'll put a tube down there to suck out any air. Okay, so that's why you have here gastric decompression. Is it up here? Okay, secretions and air may be evacuated. This tube, NG tube or any tube, can also be used to medicate, nourish, and we also have the opportunity, just like in the urinary catheter, we can also push contrast through that tube and fill up the stomach and do a radiographic study. Okay? Any questions? Okay, so yeah, so again, through the nose, down the throat, the nasopharynx, down the esophagus, ends up in the stomach or in the proximal portion of the small bowel. Drainage and secretions to remove any gas buildup, so there's your gastric decompression. Okay. For feeding, nutrients and medication, also controls bleeding. Now, for NG tubes, the names are specific. You need to know this. These tubes can either be a Levine tube, a sump, Nutraflex, or Setagaskin Blakemore are your different types of NG tubes. These are all NG tubes, but they may vary in style and use. Style and use.
So NG tubes doesn't go through the mouth?
Goes through the nose. We want to keep the mouth free. Okay? Because even if you have a tube down your nose, okay, we don't want anything in the mouth because the patients are still able to eat. So we want them to still be able to eat and drink. Okay? With a tube even going down their throat. So we want to keep their mouth free of obstruction. Okay, so here is an example of a Levine single lumen. Okay, so again, one opening. So the tip of it will go down the stomach, and then we have the other end here, which we can connect to maybe a suction machine that sucks any contents out, or we can hook up a syringe there and manually suck things out, or we can hook up a syringe there and push things in, like drugs, medication, and maybe nutrients. And if it's a radiographic study, we can put contrast through here and fill up the stomach. And then we can take radiographic images. And then you also have a double lumen sump. Okay, again, two openings. So you can take things out and instill things simultaneously. No balloon tip here, guys. No balloon tip. All right, any questions? All right. So in the nose, nasopharynx, down the throat. Man, I'm gonna need a break soon. And into the stomach. If it stops in the stomach, it's known as an NG tube. If it goes past the stomach and into the intestine, it's known as a nasoenteric. This just has a special name, nasojejunal, which is enteric. This is the second portion. The jejunum is the second portion of the small bowel. Okay. All right. So nasoenteric, same thing. Rubber, silicone, plastic, through the nose, down the throat, down the esophagus, past the stomach, and into the small intestine. Same thing here. Okay, same thing. For feeding, medication, gastric decompression, removal of any type of secretions. It does the same thing, it's just the tip of it is in a different location. Okay? One is longer than the other. The names for this are the Cantor, the Harris, and the Miller-Abbott. The Cantor, Harris, and Miller-Abbott. Okay. Radio opaque, right? So we can see it under X-ray. Why do we need to see it under X-ray?
Can you see the bath travels?
Okay.
Place it.
We need to see where the tip of the catheter goes. Whenever and this is going to happen at least a couple of dozen times throughout the day, you will have the floors, the different units, calling the radiology department saying, we need a portable chest X-ray for NG tube placement. An NG tube placement. Because once they place the catheter in there, they want to make sure that it is properly placed. What do I mean here by properly placed? Well, remember around your throat, you have two openings there. One goes to the stomach and the other one goes where?
Lungs.
To your lungs. So before they start using this tube to suck anything out or to push anything in, we want to make sure it's in the stomach or in the small intestine. Because if you start pushing things in and the tip of this is in the lungs,
It's not good.
exactly, not good. You can cause a very, very bad inflammation of the lungs, or you can cause irreparable damage.
So when they put them in, they do it blindly, pretty much? Like, they do
Yeah, they
it?
put it in blindly.
Why they don't use the fluoroscopy at the same time?
Well, they do, but they don't do it all the time. Okay?
More
The doctors, more exposure, but the doctors are so good, they can usually do it, and they can hear the sounds as they're putting the tube in. So they're putting like a stethoscope to listen where it's being placed. Okay? So, there's also like markers. There's like markings on the tubing that tells you where to place it, how far it should go. And usually if it's going, for example, let's just say if you're putting it down and it's going here and it starts to twist up, you can see this bulging outward because the catheter is kinked and coiling up. All right. But again, very important to make sure that it's in the right place before you put anything down that tube. Now, how do we know this is in the stomach?
X-ray? Anatomy?
Yeah, X-ray, but anatomy. But when looking at this, how do we know?
To the left?
Okay, you know your diaphragm, right? You guys know what your diaphragm is?
Separates the...
Okay, your diaphragm is a muscle that separates your thoracic cavity from your abdominal cavity. This is your diaphragm. The bottom of the lungs is where the diaphragm is. So here's your diaphragm. From here to here. Where is the tube going?
Below the diaphragm.
It's going past the diaphragm. So it's going into the abdominal cavity somewhere. And the tip of it is on the left side. Where's your stomach?
On the left side.
On the left side. Here's another clue. What do we know about stomach? Stomach,
It's curvy.
okay, there's two things. Well, it is curvy. It has a J shape to it. But your stomach has two different types of contents. You got solid contents from food and liquids and air. Okay? That's why you belch. You got air in your stomach and you burp. Right? Air in radiographically is black or gray. That's the stomach. So we know it's in the stomach. Good placement? You guys agree? Is it a good placement? It's a great placement. So once we do the portable chest X-ray, okay, the doctor will look at the radiographic image, and then he'll say, yeah, good to use. And then we'll call the report to the nursing unit, and we'll say, it's ready for use. Go ahead and use it. but they can't use it until it's cleared by one of the doctors. Okay?